Hey everyone, today we're going to be talking about how pain gets complicated. And this is a little different than what you've already done. You've already talked about pain in assessment, and we're going to just build on from some of those concepts, and we're going to add additional information. I really like this circular idea of pain because when we think about certain diseases, they're very linear. But pain has all sorts of different facets that it adds. There's the physical components to pain, right? That we know about. They cause pain, but then there's the perception, right? And the perception is just as real as the physical components. Pain was designed to make sure that we don't harm ourselves. So if you touch a hot stove, it hurts, you pull your hand away. That's that physical piece. But then that perception is, I can never cook again because it hurts when I cook. That's a perception or interpretation of the pain. And so we have to deal with both aspects when it comes to pain. Otherwise, you can solve one piece of it, but not necessarily the other. And that is why we have both the pharmacology treatments of pain, but we also have a lot of the non-pharmacology stuff, distraction and those kinds of things that help with that perception piece of pain. So let's talk about what we know with pain. So let's define it. Pain is whatever a person says it is, whatever they say it is. And I know that gets really hard because we have some patients that they have very little pain tolerance, and we have some patients that have a really high pain tolerance. And so that gets really challenging. Self-report becomes really important. So we want to make sure we're having good conversations and we've built rapport with our patients so that they'll be honest with us and what it is. Documentation also becomes very important with this because it's really hard to get such a complex part of humanity into a scale of 1 to 10. And so that's where we have to really document not only what they tell us it is, but then also what we see, so that we are following and painting that picture of what's going on. Pain affects all aspects of life. I don't care who you are. If you've got pain, you're going to struggle a little bit. And then every patient deserves pain management. So I don't care if they are a drug addict. I don't care if they're an 88-year-old who's never even had a Tylenol. They all deserve pain management. You have patients that are oftentimes very cranky, and sometimes that crankiness just comes because they're hurting, and so they don't have the ability to work through that and have their best PR types of skills. Let's start with some assessment stuff that we know. Onset, location, duration, intensity, all of those are all words that we've already probably asked patients as we've been assessing them. But then we want to think about the stuff we don't know. What are we building onto this? The big one is triggers. So a lot of patients will have triggers for pain, whether it's getting up and ambulating with physical therapy or it's getting ready to do a wound dressing change, something like that. It could be just turning in bed sometimes. We can pre-medicate those triggers if we know about them. So communication really plays an important role. And when you're giving report, if you know triggers patients have, like, hey, every time we turn them, they really grimace, make sure you give them their morphine before that, or make sure we get them that medication on board. Triggers are a really big thing, and they're one that we oftentimes can control. Beliefs, expectations, and goals. This is a pretty big one in actuality. So beliefs and expectations are hugely cultural, whether it's ethnicity culture or just a culture of an area. You see the TikToks all the time about farmers going into the ER, and if their wife was with them, or if their wife sent them, or if they finished the chore or not. That's a cultural goal. That's a cultural piece of pain, or what they will tolerate, what they will deal with, versus you've got people, Buddhism, Confucianism, that believe pain is a part of life and that it is a blockage of energy and that suffering is something that they go through. So culture can be really challenging. Oftentimes people will not come in or not seek guidance until they are much further down the pain rabbit hole, so to speak. So that's something that we really have to understand. The other thing too is our expectations are our goals. If you've been hit by a bus, a pain goal of 0 is going to be unattainable unless we sedate you and put you on a ventilator or something like that. So we want to make sure that our goals really focus around what can you tolerate, right? And that's going to be very unique and very individual to different people. But it's not that we want to get people a 0, because often in life, I mean, you get a paper cut, it hurts. Like, that's not a 0. So we want to make sure that it's a tolerate, that they can still do their therapies, that they can still do the things they need to do. That goes into the impact on life. When we're looking at pain, and it does impact your life. You don't want to get up, you don't want to move out of bed, you don't want to do physical therapy, you don't have the energy to go cook because you're spent so much energy on just controlling your pain and trying to tolerate it. That tolerance takes energy from people, and so then they don't have the energy to do things. So we want to make sure that we're really looking at these kinds of aspects as we're working with our patients, but having clear goals with them is really important, because again, if they have a goal of 0, we're going to have a real big challenge for working with patients, because I'm sorry, friends, oftentimes we cannot reach a pain goal of 0. Breakthrough pain can be a huge challenge to work through, and we'll work through some different medications that we use to help control some of this. But the idea of breakthrough pain is that it is an increase from the baseline. So if you have somebody who just kind of has a low state of pain or a chronic back issue or something, we're going to have just a baseline of pain. However, when they have those spasms or flare-ups or something where that pain just gets out of control, or those nerves really get aggravated, then we have what we call breakthrough pain. And we have a lot of medications that can help with it. So that's something that we always need to pay attention to. It can be spontaneous. It can be from a trigger. It can be 30 minutes. It can even be just a couple minutes where it's like something just shooting down the leg, but it can be much longer if we're not getting the pain controlled. It can happen multiple times a day, or it can happen just a couple times. So it's, again, there's no real black or white kind of thing on this one. It's very personal. It's very up to what they are feeling and doing. Common causes of breakthrough pain, when we have patients with cancer, they'll have different breakthrough pain, especially as they go through different treatments. Back pain is one. So any of those diseases that cause those chronic back pains, those can have real bad breakthrough pain and get really hard for us to control. Let's talk about the different types of breakthrough pain. So we have incident pain, which is predictable, meaning we know it's going to happen. So this would be a type of a trigger. Like, again, we knew we were going to do a wound vac dressing change, so we knew that their typical OxyContin and baclofen mix isn't going to work. We maybe need to add something that's a little faster acting while we get through that train. The nice thing with anything that's predictable is that means we can control it. We can help and prevent it by pre-treating and that kind of stuff. End of dose failure pain, this is often what we call the clock watchers. So if they are constantly on the call light, pushing the button because they know their pain's going to wear off. I had one incident this where I had some pretty severe abdominal pain, was in the hospital, and I knew as soon as I hit like that 3.5 hour mark that it was time for more pain meds, because I knew that pain medication was wearing off and I was starting to feel it was starting to climb again. So the end of dose failure pain is usually the people that the medication's just not lasting quite long enough. And so we often call them clock watchers, because we know that it is doing it. Now, if we know that means we can control it. We can go in and know that their med usually wears off at about the 3 hour mark. So maybe I need to give them a little boost of something else while I wait for its due time for the other medication. The really hard ones to control are these spontaneous or unpredictable. These are a lot of like I think of our spasms, or just really angry nerve pain. They're hard because they just sort of shoot and they just do it randomly. Like somebody will be brushing their tooth, or their teeth, and all of a sudden they're like, oh my God, I've got this shooting pain down my arm or whatever. Just they're completely random. They have nothing to do with what's going on. These ones are really hard to control. And these are the ones that they can last for a couple minutes. They can be multiple times a day. So it gets really hard to control them. So let's control what we can, and we'll respond to what we can't. So looking through the different treatments for breakthrough pain, and there's lots of them and lots of options. Lifestyle changes. So, don't lift things that are too heavy if it's going to hurt you, right? I mean, it sounds simple, but at the same time, if you've got a 3-year-old at home and they're throwing a fit and you got to pick them up, it's not always something you can do. But lifestyle changes, positionings in the bed, that kind of stuff, so that we reduce as much of those triggers that we can find out, or those things that might cause irritation. Drinking plenty of water. I know people hate that, but just keeping that system hydrated and flushed can really help benefit lots of things. Management of reversible causes if able. So if we know that there's things that are causing the breakthrough pain, again, we can manage those as much as we can. The non-pharmacologicals are nice. Heat packs, cold presses. I mean, whatever it is that we can use. Distraction is really a good one. Just kind of breathing methods to try and breathe through the different, especially if it's a spasm, if they can just breathe through it, let the muscles relax, and then it kind of gets through. But hot and cold are always a good thing to add into the mix if possible. Pharmacological management. So this gets really important. We have lots of options. In healthcare, we like to give medications to help prevent or alleviate pain. So this is anything from, your orals to we can have topicals. We can have, if they're bad, we can have IV or some sort of infusion type. So there's a lot of things. Interventional techniques, other things that we can use, like nerve blocking agents. Sometimes you get nerve blocks, like people that get their shoulders done or their something done with their arm, they'll get a nerve block for that whole arm. It'll last 24 to 72 hours depending, so it buys that time for medications to get in. If we have, I look like I spelled that wrong too. If tumor debulking, if we've got some cancer where we know the cancer is going to advance and we're not trying to necessarily stop the cancer, but we're just trying to debulk where it's putting pressure, that can be it. Other injections, when we talk about like our steroids and stuff like that, we'll go through some pharmacological here in a minute, but the steroids and all those kinds of injections that we can put in people's knees and that kind of stuff, or in spines to help work with some of those breakthrough pains. So here's some examples of different medications. We've got fentanyl, which is really big in the news. And then most of us know about morphine that we give. There's also Dilaudid. There's a lot of like bigger gun medications that we can give. The nice thing about fentanyl patches is people can be at home with them. They are really good for somebody that we know is going to have pain, like our cancer patients. The one thing I want you to know about narcotics is narcotics have no ceiling. So we can keep going up on narcotics, okay? So we can keep climbing, we can keep adding more. The things that we always watch for, right, are those safety assessments when anytime we're giving narcotics. Remember those things that you've got to pull forward, the respiratory rate, the constipation, all those things. Anytime we're adding narcotics on, we got to add the treatments for the other side of it, and things that we want to make sure we're educating families on. But narcotics actually have no ceiling. I've had a patient who has had like 3 different fentanyl patches on before. Now, it was prescribed, their dosing was correct. What we don't want to have happen is that people are just putting fentanyl patches on top of fentanyl patches, because you can kill someone that way. Like, I know it looks harmless because it's a little sticky thing, but it can, again, it's a narcotic. It's just being absorbed through the skin instead of through the the vascular system, or through our GI system. So with fentanyl, we've got some specific safety things that we're looking at, especially as a growing concern in the community. So let's talk about fentanyl patches specifically. So let's talk about documentation, always important. So you see here, fentanyl patches are really small. They are really, a lot of times, transparent, so they can be really hard to see. So it's really important that when we do a full body assessment, that we are doing a full body assessment. I've had people in trauma that have come in with fentanyl patches placed in very peculiar areas. They were just they were focusing on getting the high, not necessarily the pain management. So like I've seen fentanyl patches like between toes. I've seen them like in spots that you would not have predicted. And so a lot of times we have to make sure that we're really scanning the full body. Anytime you put on a fentanyl patch, just like any medication, we need to time and date it and put our initials on it. So that way, like if you say are working with somebody in a rural hospital and you ship them to a bigger hospital or a long-term care facility or a rehab or something, that nurse can look there and go, oh, this fentanyl patch was put on so many days ago. Fentanyl patches are usually on for about 72 hours. So that becomes a very easy and usable communication tool of when I'm a nurse and I get it and I'm like, ooh, I need to take this off tomorrow and put on a new one. So that's really important. When you do put them on, you want to apply them onto clean, dry skin on the body. A lot of times I see them on chests or arms or, backs of arms, stuff like that. A lot of times people will put them on and then put like a Tegaderm or something, a transparent dressing over it so that it just holds them on because they are small and they can peel off. We want to avoid body hair just because we want, like anything we're putting on the skin, we want it nice and sealed to the skin so that it's delivering the medication as it's supposed to. Again, we want to time, date, and initial it. That lets the next person know when it's time to change it or get it off. Make sure we are handling it safely because we want to make sure that we are not touching it. One, sticky, gooey, wet, not yours, don't touch it. But the other thing is you can absorb a medication really quick through bare hands. So you want to make sure you're wearing gloves anytime you do a patch. The other thing is safe disposal. These do not go in the garbage. They go into this little black boxes, and you'll want to find whatever facility you're working at where they do it or follow their procedure for disposal. I've had patients that will steal their grandma's fentanyl patches or whatever, and they will kind of scrape it off and all this stuff. I mean, when we have drug addiction issues, fentanyl is a really big one. It's just such a big gun, but it also is easy for people to get a hold of. So we want to make sure we're documenting the site and location. Like I said, change every 72 hours or 3 days, but you don't want to put a patch on the same spot every time. You don't want to put it over like a pacemaker or if they've got some sort of port or any of that kind of stuff. We have to be really careful. Again, these are usually really tiny and transparent, so they get really hard to see. And then always assess your patient for the patch because those patches can come off. Like maybe the CNA put them in the shower and they took a nice shower and then the patch came off. We'll need to get a new one on because it takes time to build up in the system and it takes time for them to absorb. So we want to make sure we always know where it is. That could be a piece of report, like they have a fentanyl patch on, it's on their left deltoid. Okay, great. Next time I put it on, I'm going to put it on the right side and I'm not going to stack them. Other things that can happen is if we're doing any CPR, any of that kind of stuff, the patches usually need to come off just because of the conduction issue. Anytime we're putting somebody into an MRI machine or any of those kinds of things, we have to look and make sure that they can have patches in there. So treat it like a patch and with all the patch kind of safety stuff. So let's talk about ways that we can manage some of these complex. We're going to talk about our adjuvant analgesic therapy. These are drugs that can be used alone or together with an opioid or non-opioid to try and help manage these are our complex pain managements. So it's not going to be somebody who just has a broken toe and we give them some Advil and we send them on their way. This is going to be somebody where they've got like other things going on, muscle spasms, cancer pains, lots of broken bones from a trauma. Maybe they have MS, and so they've got very complicated things. So that's part of it, is we're going to have to look at all of these. They're typically used for other reasons, but that's why all of a sudden you'll be like, I have a patient that's taking an anti-seizure med, but they don't have seizures. Well, they're taking it for this other reason, and we'll work through some of those. So like it says examples, anti-seizure meds, anxiolytics, and then antidepressants are all potentials that we might use. So one is tricyclic antidepressant, which enhance the descending inhibitory system by preventing the cellular reuptake of serotonin and norepinephrine. Basically, it's an antidepressant. If you have chronic pain, you're probably going to have some depression issues because you're constantly battling that pain. But this can help with some of that reuptake of the serotonin. It's really good with those neuropathic pain syndromes, so those nerve pains, because those get really hard to manage. But being an antidepressant, or it has the dry mouth, the weight gain, so it has some of those side effects that people aren't huge fans of. Amitriptyline is one that we use. I think they see this a lot more with the cancer patients and that kind of stuff. Anti-seizure meds, I've seen these frequently used for patients, again, because if a lot of times it's nerve pain, and nerve pain is so hard to control. So these are going to work on that central nervous system or the peripheral nerves that are coming. It really can help a ton. So this might be a patient that you see that you're like, oh, they're on an anti-seizure med, but they don't have a history of seizures. No, it's that they have nerve pain and we have to treat it. So like your diabetic neuropathies, I see a lot of gabapentin used, or Neurontin used. Pregabalin is your Lyrica. So those are both ones that I see used a lot for our patients with nerve pain. A lot of back pains, a lot of cancer pains, any of the nerve pains that we get. One thing that's really important to understand is with gabapentin, this is becoming a drug of abuse now because it potentiates actually both of these are, but gabapentin is an interesting one because it potentiates the narcotics as well. So a lot of our opiate abusers can't get a hold of all the opiates, so they'll do gabapentin and then do a smaller dose of opioids to help potentiate it. So it is a medication. We thought, oh, no big deal, no one will abuse it. Now it's starting to get abused for its effect on its opiate uptakes and that kind of stuff. So GABA receptor agonists are going to be more your baclofen and your diazepam. These are really great for those muscle spasms that we see with a lot of our patients, especially our MS patients. You'll see a lot of like baclofen, and they can give baclofen pumps. So you'll see that in patients that have a lot of chronic pains, and this can really help just decrease some of those spasms and that pain that comes with it. Corticosteroids, what would we do without them? They are super great at helping with the inflammation and the edema that a lot of our chronic pain patients have. So one that I think of a lot is our brain cancer patients. As the tumor grows, it puts a lot of pressure on the brain and kind of squishes the brain against the skull. So we use a lot of anti-inflammatory and edema control for them. Other ones you might see, like your MS patients who have a lot of chronic pain with other things, just bring down some of that inflammatory process. It can be used acute or chronic. And then we want to really look, just like with anything with our steroids, that increased blood sugar, they can have fluid retention, decreased healing, increased infection, like all the things that go. Most of these are going to be from our orally ingested steroids and something that is systemic. They're not going to be necessarily from our inhalers that we take because those are going directly to the lungs. These effects are a lot of times more with our orally and our chronic use. So somebody who's chronically taking steroids or keeps bumping them up to help, but they really do work. We see a lot of dexamethasone, prednisone, or methylprednisolone for those patients. Anesthetics are something that we don't use a ton. We use a lot more like in the ICU level, but you do see them for like your big surgeries or your big traumas. So you might see an anesthetic given, like they call them a walking epidural a lot of times for our patients who have had really extensive abdominal surgeries that they've had to do a lot of tiptoeing around the intestines and messing with them. So they might have an epidural in where they have this, but this is going to be very specialized training. You're going to have it's going to be treated a little bit more like a PCA that we've talked about. It's very specific. So these are going to be things that are big, bad, and awful, not usually used for, like they're kind of a last ditch effort for managing pain. And again, they're usually more your traumas and stuff like that. One that we're seeing more is our cannabinoids. This is coming from the marijuana plant. It actually works really well for neuropathic pain. It also has an ability to increase appetite, which is again really good for our cancer patients. So we see it a lot with our cancer patients, patients that have really hard to manage pain. We will see this used. I think Methodist uses the dronabinol. I've seen Marinol used, but it has a really great effect, and it helps people sleep, and it helps people get that appetite a little bit so we can have nutrition in their system. So it has a lot of things. It is very controversial, so we have to be really careful with that aspect of it. It is treated like a narcotic for counts and all that kind of stuff. So we're usually pretty careful with it, but it has some really good benefits as we continue to work with understanding the drug better and its uses. You've heard me talk a lot about pain and cancer, and it's because most of our patients, so 50% of patients who are getting active treatment have moderate to severe. 80 to 90% with advanced cancer have pretty severe pain. It is incredibly undertreated because we get so worried about all these other issues that come with our narcotics. We get worried about addiction. We get worried about tolerance. We get worried about, oh, that's too much. Well, here's the deal with these patients a lot of times is that they have increased their tolerance to the medication. I had a young man that was like in his 20s. He had leukemia. He was dying from his cancer, and I was giving him like 20 milligrams of morphine every hour. Thank goodness he had a PCA that we could work with, but that's one of those challenges that we have to work with, is that he had built up a tolerance. He was still smiling at me. Let's keep their pain under control and not worry so much about addiction. At this point, is that something we're going to have to worry about? Yes, but that's kind of on the other side. If we don't treat their pain, they have a ton of suffering. Their increased caregiver strain because those caregivers it's hard to watch someone you love be in massive amounts of pain. So whatever is causing that pain, it's incredibly hard. So it helps our caregivers to give them this, and then it decreases the quality of life. So make sure we are really, really advocating for pain control for our patients. So all of these things that we've talked about are a piece of the puzzle when it comes to pain management. And again, talking a little bit more specifically about our cancer pain, because that just is such a complicated pain for these patients, is we have to find a balance of quality of life and analgesics, right? So if we give too many analgesics, they're sleepy, they're not enjoying life because they can't do anything. But if they're in pain and can't get out of bed, they're not enjoying life either. So it is a very big challenge to find that balance. So we have some meds that we call ATC, which are around the clock. So we're going to give them around the clock. I don't care if I have to wake you up at midnight, I'm giving it to you because I know at 6 a.m. that pain will be excruciating, and then we're playing catch up. We've got PRN medications, which are as needed. So those are the ones that we're going to give kind of for those breakthrough things, or if we're not managing the pain well enough, maybe they're just having a flare up and they need a little extra of those oxys or the morphine or something. Again, we're going to do it with doctor's orders, but we are the advocates for those patients, and so we're having to make those phone calls. Then we have the multimodal approach, which again, we're looking at all of those different pieces. Is there a muscle relaxant we can give to help with some opioids, and then giving some, wellness and support and getting them up. I know patients, a lot of times they don't feel good. They don't want to get out of bed, but sometimes getting out of bed and taking that warm shower really, really helps with them. So those are the things that we want to make sure of. We pay attention to all those constant side effects. That constipation, I'm sorry, you can go from having horrible pain and cancer, and then we get you constipated because we've given you so many pain medications, and now you're not pooping, and not pooping hurts. So, we got to make sure we're keeping that system walking through. Toxicity, we always want to make sure we have a plan for if something goes awry and we give too much. But again, these patients have built up such a tolerance that a lot of times we're giving them, like, I give them medications and I'm like, I feel like I could kill a horse with this medication, and it's they're tolerating it because their body has built up the tolerance to it, and so they have to have more for it to have the impact and the effect that we need it to have. So really work with your cancer patients, work with all your patients, but your cancer ones, they really struggle with their pain management. Just to make sure we recap on this, managing cancer pain, just because it has such specific and varied approaches, we really want to discuss goals. So again, if the person has tumors eating into their spine, we're probably not ever going to get them to a 0. And if we make that goal of a 0, we're going to fail every time. We need to be realistic and set attainable goals with them. So maybe theirs isn't necessarily a number, but it's, I can get up and go to the bathroom without crying. Like, that's not a number, but that is a very hopefully achievable goal. Maybe it's that we move the commode closer to their bed so that they don't have to move as far while they're doing it. Maybe it's, we know we're going to give them morphine, so before they go and take their morning shower, stuff like that. Like, those are attainable goals, but it takes teamwork and working with the patient and their family. Trust the patient and their family, because here's the other challenge is, again, we talked about that cultural and those belief systems and what pain means. Some patients feel that they need to feel pain in order to heal, but then they don't get out of bed and they don't take those big deep breaths that we need them to take and all that kind of stuff. So we have to really work with educating them and breaking down some of the barriers that we have when it comes to that. And that's something to think about. We need to educate patient on medications, because they do get real worried, like, oh, my grandma's going to get addicted to opioids. Well, if grandma's 88, and our goal is to keep her comfortable, then that's not really the worry or the concern at this time. The other thing is our non-farms. I know that sounds really dumb, but they are so powerful. Meditation, aromatherapy, massage, distraction. Like, when you're laying in a bed staring at a TV or whatever, you're going to feel everything, because there's nothing really there to distract you or to make you feel better. So sometimes just going in and having a conversation, giving them a puzzle to do, giving them something to do that even if they can't do it as fast as they would have, it still takes their mind off of it. When we focus on things, we feel them more. So if we can create that distraction, that's great. Make sure we're always evaluating it, what works, what doesn't work. Because if as a nurse, you've done night shift and you're like, ooh, heat compress did not work for them, or, man, I gave them a warm blanket and some pain medication and they snugged right down and went to sleep and had a great night's sleep, that can really help us know what works and what doesn't work. And we're not playing every 12 hours, we're playing catch up of what worked. The other thing is listen to the family, because a lot of times the families know what works, and so because they've been dealing with this at home. Addiction and tolerance, we talked a little bit about addiction. It's not usually something I'm too worried about in the immediacy, but if they are an addict, they have an increased tolerance, so we might have to adjust the medications. Tolerance is something we always have to battle. I had a patient that used to come in. She, her foot had broken, hadn't healed right. She then also had some addiction issues. And so she would always come in and have to have Dilaudid right away for pain management. But if we got her the Dilaudid, she actually would get feeling better, so then she could do the therapies and withstand some of the dressing changes and that kind of stuff. And so she was a much better patient and healed much faster from her infections and that stuff. So even if they have tolerance, we need to work with them. And that tolerance sometimes comes from addiction issues. Keep our judgments at the door. Our goal and our job is to help people get better. And sometimes we have to give them the medications and we have to deal with the consequences of those medications later. I don't know how much to reiterate that evaluation is probably one of our biggest things, and we're kind of not super great at it, right? We give the hydrocodones, and then we walk out of the room and we go deal with 3 other patients, and then we have trouble getting back to evaluate whether the pain medication worked. If we don't evaluate it, we don't know if it worked, and then we don't know, then a lot of times we're playing catch up or we're still guessing what might work. So we want to make sure that we're evaluating. I don't care if you give a warm blanket, evaluate it. If you give an ice pack, evaluate it. We're constantly doing it. We're going in the room, checking on them, seeing how they're doing. That's an evaluation. It may not seem big and formal, but you're actually going in and seeing how they're doing. So that's something to pay attention to. We want to make sure that we're documenting it, because if you didn't document it, you didn't do it. So make sure you document. This becomes a challenge because we're just busy and we get it, but we want to make sure we document our evaluations so that we know what we're doing is effective. Guessing is never going to be beneficial for our patients. We want to make sure we're frequently assessing and we're evaluating and reevaluating, just kind of like I talked about. And then establish rapport with your patient, because if you establish rapport with them, they're going to trust you. They're going to tell you things that they wouldn't necessarily tell other people, like, it really hurts when you do that, or, otherwise they might just try and suffer through it because they don't want to be a bother. So building that trust with them, making sure that our goals are the same and aligned together, comes from that rapport building. Like, hey, George, I know when I turn you, it hurts. We're going to give you some medication for that, and then we'll get you comfortable. Okay. So building that rapport with them is really important.